So we hope that at the end of this presentation that all of you will be able to describe the relevant anatomy and function of the rotator cuff, that you can recognize the natural history of rotator cuff tears and understand the classification of rotator cuff tears and our general treatment recommendations and how we make those decisions. We also hope you can develop a treatment plan for older versus younger and active versus inactive patients with rotator cuff tears, because there are certainly differences that you need to take into account. So I wanted to start with a case presentation. This was a 52-year-old right-hand dominant male who presented with about 2 months of right shoulder pain. He denied any history of trauma. He was complaining mostly of pain with overhead motion and with carrying heavy objects. He was also having a lot of difficulty sleeping, secondary to shoulder pain. So on exam, he had fairly normal shoulder range of motion. I mean, it was really limited largely by pain, which was at the extremes of motion. He was able to elevate his hand off of his back without difficulty. He did have tenderness over the bicipital groove and had positive Neer and Hawkins tests. These were his x-rays in clinic when I saw him. So on the far left, that's a decent true AP, not a perfect true AP or a Grashy view. And so that's a kind of an image or a name you guys should file away, but it's not perfect there on that left-hand side. The middle view is a scapular Y. And on the far right, you actually see a Bernajot view, which is sort of like the ice cream scoop on the cone. And his x-rays are normal, right? X-rays obviously just show us the bones. And most of the time with just standard rotator cuff pathology, rotator cuff tendonitis, or rotator cuff tears that have not been there for a long time, most of the time the x-rays look pretty normal. So our initial plan for him was to do a subacromial steroid injection, have him do physical therapy, and take some anti-inflammatory medications. And when I do the steroid injections, I actually usually use a combination, and I think most people do. And actually, I'll ask Winston and Jeremy their thoughts on this, but I usually will use I use Depomedrol and Marcaine. I like Marcaine because it's a little bit longer acting than lidocaine, but we'll combine those two medications and do a single injection. The Marcaine starts working pretty quickly, and the steroid can take really about 3 to 5 days to kind of kick in, which is the benefit of using the local anesthetic. So Winston, listening to sort of take away is that they do often have sort of a little spike in pain, and they don't understand why that is. But that's a good point. It's when the local anesthetic is wearing off, and it really does take a few days for the steroid to start working. I will also often tell them to put ice on their shoulder or their knee that night. It's a little bit sore, and the ice can help. So, all right. So that was the plan for this guy. Initially, we did all this, did the injection in clinic, and then had him do some PT. And so we will get back to that case a little bit later. So for the rotator cuff, it's a group of 4 muscles, right? The sits muscles. This is what you learn in medical school. So this consists of the subscapularis, supraspinatus, infraspinatus, and teres minor. So the subscap is actually the biggest and most powerful of the 4 rotator cuff muscles. It sits on the front of the shoulder and is responsible for internal rotation. And then you have supra and infraspinatus right on the posterior aspect of the shoulder, and the itty bitty teres minor there most inferiorly. So in terms of innervation, the suprascapular nerve, which is C5 and 6, innervates the supraspinatus and infraspinatus muscles. The axillary nerve, which consists of C5 and 6, innervates the teres minor. So in terms of anatomy and stability of the shoulder, there are static stabilizers, which consist of the glenoid. So the glenoid is just like a golf tee, right? So it's tiny, and you have the golf ball, which is the humeral head sitting on top. The labrum is a very important static stabilizer. It goes around the circumference of the glenoid. And then you have the glenohumeral ligaments, so the superior, middle, and inferior glenohumeral ligaments, and the capsule, and all are critical for providing static stability. The dynamic stabilizers consist of the rotator cuff, so those 4 muscles we just talked about, the deltoid, and then you have pec major and lat dorsi, and the scapular stabilizers. Additionally, there's negative intra-articular pressure and this concavity compression mechanism, and so all of these things are very important. In terms of rotator cuff function, so for each of the rotator cuff muscles, obviously they have a very specific function. So the supraspinatus, and anybody, let's just chime in. I'm just going to throw out to the group too. What does the supraspinatus do? Please put some stuff in the chat there. I'll move on to the infraspinatus. So infraspinatus is responsible for external rotation with the arm by the side, right? Subscapularis does internal rotation. And usually, right, so the way that if you've shadowed anyone in clinic, sports medicine or shoulder surgeons in clinic, we measure internal rotation by vertebral level, right? So we will say internal rotation to T12, estimating. Of course, we're estimating. And so that's an important point that we put in our notes. I'm going to actually circle back to the chat here and let's just see what we have. So great. Yeah. So you guys are all right. See lots of right answers here. The supraspinatus functions in abduction, and it's the first 15 to 20 degrees of abduction. And as a follow-up question to that, what then takes over for abduction? And so subscap, so this is, we look at behind the back, right? That's internal rotation. That's how we measure that. And an important follow-up, which we'll get back to actually, how, what's normal internal rotation. But subscap is internal rotation. Teres minor is also external rotation, but that's external rotation with the arm in abduction, and then you externally rotate from there. Okay, so arm in 90 degrees of abduction, 90 degrees of flexion there, and then you externally rotate, or sorry, 90 degrees of abduction and then external rotation from there. That's teres minor. Okay. There's a really important force coupling concept where the muscles on the front balance out the ones on the back. And so that's very, very important. Cuff problem, it's a big problem, right? This is incredibly common. One of the most common things that we see in clinic. So about 4.5 million visits per year for shoulder pain, more than 250,000 rotator cuff repairs performed annually. When we look at age breakdown, so 20 to 50% of patients over the age of 60, more than 50 to 80% of patients over the age of 80 have cuff tears. Patients over the age of 65 with a tear, about 50% of them will have an asymptomatic contralateral tear. More common in males or laborers, those that smoke, that's definitely a major risk factor, and dominant arm. Tears are likely to progress over time, and bigger tears progress faster. We can't say definitively, oh, your tear is this big, it's going to progress this much in this period of time. Like we can't be that specific. And interestingly, pain does not always correlate with size of tear, right? You can have patients with a huge tear and they really don't have much pain, or small tears and they have a lot of pain. 50% of asymptomatic tears will become symptomatic within about 3 years. So in terms of evaluation, history is very important. It's critical to differentiate a history of trauma. And we just had a great discussion about this because that does change our management. For older patients, often they have no history of trauma. They'll come in just saying, well, my shoulder's hurt for 6 months or 8 months or 2 years. And really there was nothing specific that caused that to start. There's variable history of trauma in patients age 50 to 60, and in younger patients, often they have a history of high energy injury. And in those patients, we're going to be ordering MRIs right away. Most commonly, when patients come in, they're complaining of night pain, so that their shoulder really bothers them at night. I think that that's largely due to two things. One, they're not distracted by anything like they are during the day. And two, when you lay flat, the shoulder rides up, and that causes a lot of discomfort. So if patients sleep a little bit propped up with pillows or with, in a reclining chair, their shoulder will often feel better because gravity is their friend. Patients will complain of weakness. They have pain with overhead activities and difficulty reaching behind the back. Physical exam, as with any other type of physical exam, right? We certainly want to do inspection. We can compare that to the contralateral upper extremity. We evaluate active and passive range of motion, strength. We're assessing for impingement signs, AC joint pain. We're looking for labral and biceps pathology, and looking at the scapula in comparison to the contralateral shoulder. When evaluating the cuff, we look, a lot of times in the presence of cuff tears, patients have weakness and decreased range of motion. They may have atrophy in really advanced cases. And an exam is critical, right? This can give us tons of information, and it's our primary method of diagnosis. So this article is fantastic. This was published in the Yellow Journal in 2019, comprehensive review of shoulder and spine exam. And we're going to touch on some of these, some of the key points. So near Hawkins and painful arc tests are very helpful impingement type exams, and you have the different percentages and sensitivity and specificity, but these are all really helpful. Winston touched a little bit on near test and near sign. I can't remember if the subsequent slide, I don't think those go into it, but so near test is, and I mixed these up, so Jeremy and Winston, correct me. Near test is actually when the patients are forward flexing, right? And you as the examiner, you can actually kind of stabilize the scapula, but they will forward flex, and pain with that is considered positive. Near sign is when you inject the lidocaine under sort of the anterior aspect of the acromion, and relief of pain is considered positive. And so that distinction, it's slight, but it's important to remember. And we Actually, I don't personally do this. I wonder if Jeremy or Winston, if you guys do this, and maybe this has changed with time, but I don't often just do that to say like, oh, do you get pain relief immediately, right? Are you getting, that sort of near sign? Are you getting relief of that discomfort immediately in clinic? I don't specifically make note of that. Do you guys do that? And then, so Hawkins test is when the arm is forward flexed and then you internally rotate and it's pain sort of over the anterior aspect of the shoulder. Patients will often have pain in that area with rotator cuff pathology, rotator cuff tendonitis, rotator cuff tears. And painful arc is pain in about 70 to 120 degrees when the arm is being brought up in the plane of the scapula. So those are all important things to make note of. So we have a few slides here demonstrating some of the physical exam tests. So here you have Job's test, where the arm actually is in the plane of the scapula here, and the examiner is applying some downward force. And here is just looking at external rotation, so against resistance. As we talked about a little bit earlier, so infraspinatus is responsible for external rotation. So this is evaluating the strength of the infraspinatus. And then here, this is evaluating teres minor. So on this slide, we have two tests that evaluate the subscap. On the left-hand side, we have the belly press test. Key things to note here is that this patient's wrists are straight. They have to be straight. Patients will sometimes try to cheat. They're not doing it on purpose, right? But it's because they have pain or the subscap's not functioning normally, but the wrist needs to be straight. And so he's pushing on his belly, and then the examiner is pulling away. You can also do kind of a modified test called a Napoleon test, where the patient is pushing on their belly, and then you have them forward flex their elbows. So it's hard to sort of see me sitting here. I realize that. But basically, instead of his elbows being directly in line with his chest, so you can see Jeremy a little bit. Exactly, yeah. You bring those elbows forward, and then as the examiner, you just apply a little bit of posteriorly directed force against the elbows. On the right-hand side, you see the lift-off test. We commonly use this to evaluate the subscap. So these two tests evaluate really one part of the subscap, and Berg is fantastic, and really specifically evaluates the proximal aspect of the subscap or the superior portion. So key things for you guys listening. So the bear hug is the affected. So if it was my right shoulder that hurts, right? So I'm using my right hand and I grab the left shoulder. And the key thing is the elbow has to be up. The elbow has to be forward flexed. And then the examiner tries to pull the right hand off of the left shoulder. So you tell the patient, hold on to your shoulder as tightly as you can. And you as the examiner then try to pull the hand away. When the subscap is torn, weak, they're in a lot of pain, you can easily pull that off and use the other side to compare, right? And so the patients are grabbing. The subscap is huge. The subscap is very strong. So patients should have no trouble holding on to their shoulder when they're activating the subscap. So if they do, then there's a problem with the subscap. Imaging, very important. We always start with x-rays. We touched on a little bit with my patient's x-rays at the beginning of this. A true AP or a Grashy view, that's important to file away. This image here in the top left-hand corner, that's a good true AP. What we mean by a true AP is that an AP of the shoulder is not, or rather an AP of the chest is not an AP of the shoulder, right? Because the glenohumeral joint is sort of anteverted. You need to angle the beam towards the glenohumeral joint. So it's about 15 to 20 degrees that the beam is angled to actually get that true AP, that perfect view of the glenohumeral joint. We use the Grashy view to look for glenohumeral joint arthritis, proximal migration of the humerus, cuff tear arthropathy, any type of decentering of the humeral head. The scapular Y or outlet view, which is that top right-hand corner, allows us to, number one, see is the humeral head centered? It's not dislocated, right? So for a patient that may have dislocated, you reduce it, you're getting x-rays. That's one view that you can look at to show that it's centered. You can also use this to evaluate the type of the acromion, right? Does it have a big hook? Is it pretty flat? The axillary lateral view, which is the bottom view, that is where the beam is actually angled up or aimed up through the armpit. And so you can see the humeral head and the glenoid. We can use this to evaluate glenoid bone and version, any subluxation of the humeral head, look for ossicromiale or AC joint arthritis. All these views are important. So you really, really, really need all of them. One is not sufficient. At a minimum, you need orthogonal views, right? You need two views that are perpendicular to each other, especially in a case where you're like trying to rule out any instability or dislocation or whatnot. but just in general, like you need all of these views to thoroughly evaluate the shoulder.
And never let a patient leave the ER with a shoulder injury without an X-ray view.
No, and if they can't get it for some reason, any reason, get a CAT scan. You have to get a CAT scan.
Yeah, they can always get even a Velpo view. They can get a view. You have got to get a view of the humeral head in the socket, or else it's incomplete.
Yep. Other types of imaging, you can get a CT arthrogram. We don't usually get that. The main reason we would do that is if there's some reason that a patient cannot get an MRI. And then ultrasound is definitely something that can be used as well. It's technique and operator dependent, but can be very helpful if you yourself are trained to do this, or if you have someone in your clinic or group that is skilled at doing it. And an MRI really is our go-to for evaluating the rotator cuff. So as mentioned, it's the best study for visualizing the rotator cuff and surrounding structures. It's incredibly sensitive. It's so sensitive that you can identify like minor structural abnormalities that really are not causing any problems. The view on the bottom left is a coronal image. It shows a rotator cuff tear, which you can see they're measuring there 1.77 centimeters. That area, when the cuff is normal, that's just a nice sharp black structure that attaches to the humeral head. So the fact that you have all that bright signal there, that's where the tear is. And then the view on the top right is an axillary image, and they're marking that out. That's a subscap tear, so you can see the subscap muscle belly. I don't know if you guys can see my mouse here, right there. Do you see the mouse? So that's subscap muscle belly. You have the humeral head and the glenoid, and then you have the tear right there. The biceps sits in the bicipital groove, and that can help you orient yourself when you're just sort of learning how to read these images. So the biceps is there on the anterior aspect of the shoulder. MRI is great for evaluating the rotator cuff. You can also use it for the labrum, although really the majority of imaging centers in the country don't have very high powered MRIs. So I would think potentially a 3 Tesla magnet you could use to evaluate the labrum. I think otherwise, like you really need an MR arthrogram. So other things on the MRI, we evaluate the biceps. We can sort of evaluate the superior labrum, although I think that falls in the category of really being better evaluated on an MR arthrogram. Fatty infiltration, Winston touched on, and we'll see that on some images coming up. Cysts, and then retraction of the rotator cuff. So there are several ways to classify rotator cuff tears: acute versus chronic, acute on chronic, which is enlargement of a smaller tear. Which rotator cuff tendons, right? Is it just one? Are there multiple tendons involved? And then the size and amount of retraction, is it full thickness versus partial thickness? And what's the definition of massive rotator cuff tear? So we're going to touch on that in the next slide. This image here on the right-hand side, again, this is a coronal image. You see the humeral head, the glenoid, and then this fluid here, that's where there's a rotator cuff tear. And I hope, can you guys see my mouse? Okay, good. So massive rotator cuff tears historically have been defined as greater than 5 centimeters of retraction of the rotator cuff, or a complete tear involving more than 2 tendons. More recently, massive cuff tears are defined as 2 or more tendons, or at least 1 tendon that is retracted beyond the humeral head. This Goutallier classification system, Winston sort of touched on this idea a little bit. It was originally described on CAT scan and best viewed on sagittal images. On the next slide, we're going to touch a little bit about how we're actually translating this to MRI, because obviously we use MRI way more often to evaluate the rotator cuff. So for Goutallier, grade 0 is no fat, 1 is fatty streaking, and this goes all the way up to grade 4, where there is more fat than muscle. Now, the reason this whole concept is important, and here I'll show the MRI images, but the reason we even talk about this is because the quality of the muscle belly is an indirect indicator of the quality of the tendon, right? So if there is a ton of fat in the muscle, there's very little sort of normal muscle content, then that tells us the tendon itself is going to be very poor quality, and makes it really likely that the tendon will not be able to hold the sutures, which is what we use to repair the rotator cuff. So if the tendon is weak, if it's like paper thin, then we tell, this helps us also educate our patients. So we tell them, look, you have actually a lot of fatty atrophy. It's definitely possible that we are not going to be able to completely repair that tendon. It's oftentimes still worth trying to repair it, even to do a partial repair, but that's why we care about this so much. And so this study looked at basically translating this whole concept of fatty infiltration from CT to MRI. And you can see the classification system they laid out there. The image on the far left is normal muscle bellies. On the far right is where you see a lot of fat replacing the muscles. So non-op, as we touched on, most of the time we're starting with non-operative treatment, right? Our goals are pain relief. We certainly hope we can improve range of motion, improve their function and strength. We will often have them take a dedicated course of anti-inflammatory medications. There's a whole slew of them, some of which are listed here. Physical therapy is absolutely critical. And I always tell patients, right, this is not a full-time job. We're not expecting you to do physical therapy 5 days a week, et cetera. I tell them once a week, at least twice if you can go, and then every day, exercises every day at home. Because sometimes patients just freak out. They say, I have a full-time job, I have a family. How can I go to physical therapy? If you boil it down a little bit to something that seems a little bit more plausible, feasible, like they are more likely to go. And it's really important. And then the corticosteroid injection, we've had a great discussion about that. I guess I'll ask the question here, though, to you guys now. So with a steroid injection, how long would you wait after that to do surgery?
I usually wait at least 6 weeks. I tell folks, some there may be some benefit waiting 3 months. I think the studies have shown you should wait at least 6 weeks. There's some that say 3 months is better than within 3 months. But, I think 6 weeks is a fairly middle of the road way to do it.
Yep, Winston.
Yeah, ideally as far out as possible. 6 weeks, 3 months. In general, I'll say get a cortisone shot and come back and see me in 6 weeks. In which case, then I can book them. So it's usually some time after 6 weeks. But the literature suggests there's increased infection risk, maybe increased failure risk if you do it too soon after surgery. So the infection risk is so low that I don't worry too much about the infection risk. But 6 weeks I think is a good number.
Yeah, I agree with 6 weeks as well. I think we have definitely seen some studies in the past few years speaking to this. So it's a real issue, or a real something that we should take into account. And I do tell patients that. All right, let me get back to this. Sorry. Okay, so indications for surgery, certainly failure of non-operative treatment, all the things we just discussed, acute traumatic tears, especially in younger patients, and acute loss of strength or motion, good quality muscle on MRI with absence of fatty infiltration, that's a relative indication, and no significant arthritis. Contraindications, a chronic infection, advanced arthritis, right? We're not going to try to repair a rotator cuff in those patients. They probably would be more likely to get reverse total shoulder, which we'll touch a little bit on at the end. Chronically retracted tendons, those with fixed proximal migration or decentered humeral head, and those with deltoid or axillary nerve dysfunction. Operative management, there are several different ways this can be done. So it can be done open, mini open, or arthroscopic, which is far and away the most common method that we use today. These are several different instruments and implants that can be used to fix rotator cuff tears. So on the left, that looks like probably just a tap for an anchor. The middle picture is some type of anchor. There are so many anchors. There are all suture anchors. There are, strong plastic anchors. There are metal anchors. We don't commonly use metal anchors for the rotator cuff now. The picture on the right, top right, is a bird beak. That's just a type of piercing device. Bottom left are several different types of cannulas that can be used, and we will often use cannulas to help us with, getting in and out of the glenohumeral joint or subacromial space when we're doing our rotator cuff repair. And then the middle picture on the bottom is just a shoulder tray. Basically, that's everything that's going to come when you're doing this type of case. The picture on the right is a suture passing device. It's technically called like an antegrade suture passing device. So that is going to here on the end. Okay, so there will be a needle that comes up through the end, and it actually pushes the suture up through the top of this device and through the tendon. Some of them are self-capturing, which means it will grab onto the suture and then you pull out this instrument and it holds onto the suture. Others, it just pushes the suture through the tissue and you have to use a separate instrument to actually grab that suture. So arthroscopic rotator cuff tear repair, we make teeny tiny incisions. These are about 1 centimeter incisions. We do a lot of work through those incisions. We use saline that's pumped into the shoulder. We can use a pump or a gravity flow. I tend to use gravity. You can do either, right? Bottom line is we're putting a lot of fluid into the shoulder, and then we use specialized instruments to work through these incisions. And we just touched on some of the instruments that we use. We're viewing everything on a screen, right? So we're not actually staring at it. We're working totally off of what we can see on the screen. So if there's bleeding or the screen's not working or the light's not working on the scope, we can't do anything. And then we use suture anchors to actually repair the rotator cuff. So the anchor goes into the bone. That, many times we're using anchors that are loaded with sutures, but Winston made a great point that they're, depending on where you're working and what your goal is, there are also anchors that you can feed a suture through it if you want to, and they don't come preloaded with anchors, or with sutures rather. Open rotator cuff repair. This is done sometimes, not nearly as common as it was, several years ago. And you can also do this via mini open incision where you're going through the deltoid, and then you have a great look at the rotator cuff. So back to our case, just kind of closing out this case. This is our 52-year-old right-hand dominant male who had, rotator cuff related symptoms, biceps tendonitis. He continued having pain after participating in therapy. So at that point, we ordered an MRI. We have a couple of coronal images here. You can see his rotator cuff tear. And then on the far left here, we see the sagittal image. I just have labeled the supraspinatus, infraspinatus, subscap, and teres minor, so that you can kind of get an idea of where those muscles are located and what it looks like on MRI. The middle picture is another sagittal, and that fluid there, that's where the tear is. The picture on the far right is an axial image. It's a little bit fuzzy, actually a little bit blurry. And I just have pointed out there the biceps tendon. So we went on to do a rotator cuff repair for this patient. The picture on the left, these are intraoperative pictures. The picture on the left, I'm sorry, I'm like basically right on top of the biceps there, but you can see we're pointing at that. The humeral head is on the right-hand side of our screen, and on the bottom is the glenoid. The picture on the right is a little bit better view of the biceps. I have already percutaneously passed a suture through the biceps to kind of maintain control of the tendon, and then I release it from the superior labrum. I do this actually relatively frequently. If the biceps is involved, I will incorporate it into my rotator cuff repair, and I'll just pass the suture percutaneously. So here we're in the subacromial space, and so we can very clearly see the patient's rotator cuff tear. We're staring at the glenoid. We should not be seeing that. The rotator cuff should be covering that whole area. And on the right-hand side, you can see I have already passed the sutures through the tendon. I used an antegrade suture passing device. I used a single triple loaded anchor here. And it really, for all of us, depends on the size of the tear, the nature of the tear, like how many anchors we're going to use and how mobile the tendon is. But in this case, I used a single triple loaded anchor. I will then tie the sutures. I like to tie the sutures on this middle row. And then I put a single anchor laterally. And so this is the final repair construct. All of you that are on the call too, I mean, you see there's a lot of different ways to do this. There's no right or wrong. You just need to do whatever the tear sort of requires, right? We want to just make sure that we get a good repair of the tendon, that it's not under any tension, and that it's, that we have repaired it to the rotator cuff footprint as well as we can. And Jeremy touched a little bit on this. Not sure if everybody picked it up, but there's different types of sutures too. So here, these are fiber wire. These are relatively thin, but they're super strong sutures. Newer anchors have a type of tape, which is a little bit broader. And so there's just different types of suture constructs that you can use. And, studies, there's a lot of different studies, and there's not one proven better way or better type of suture, but just when you're seeing these cases, pay attention to those types of things too. Complications, certainly there's a risk. There's risk with any surgeries that we do. The risk of infection is less than 1%. You can get deltoid dehiscence after an open cuff repair. Recurrent tears and failed repairs definitely happen more often with larger tears, those tears that are under tension. Patients, that are older, that smoke, that have diabetes. Stiffness is a risk, and you may end up having to go back. In those cases, it's not common, thankfully. And then missed pathologic conditions, so biceps tendonitis, AC joint arthritis, frozen shoulder. So obtaining a thorough history, physical exam, imaging, all of that's important to really lower the risk of missing anything. There are a couple of questions here. I know we're like rapidly approaching 8 o'clock. I hope you guys are getting some good stuff out of this. The stuff at the end of this talk actually is just more sort of complex rotator type stuff. So I'm not too worried if we don't get to that, because you guys can revisit this on the Ortho Access website at your leisure. So this question, 47-year-old healthy active patient presents with a subacute full thickness supraspinatus tear. His exam was positive for significant weakness and pain with abduction. He didn't have any shoulder instability. His radiographs showed a type 1 acromion, which is a relatively flat acromion. His MRI shows a crescent-shaped tear, 2 centimeters of retraction, and there was no fatty changes. He did have a subacromial steroid injection 6 weeks ago, which only gave him about a day of relief, but no improvement in his strength. And so what at this point is the most appropriate treatment option? Like a little bit of a tweener, right? Like he's had the steroid injection. He hasn't, at least we don't know from this presentation, has he done physical therapy? Did he do some home exercises? Does he have a friend who's a physical therapist? We don't know. But I agree with everything that Winston said too. I mean, he's young, has a tear, retracted tear. He's done some type of conservative treatment, probably at this point going on to do a cuff repair. All right. The second question, 73-year-old right-hand dominant female with a right shoulder injury, shown in the image on the right. She denies any shoulder pain prior to a fall at work after slipping on water about a month ago. She smokes a pack of cigarettes per week. And which of the following characteristics of this patient confers the highest risk of not healing after repair? I think the absolutely critical point is counseling them, telling them, setting expectations, helping them understand that there's a much higher risk of failure because of smoking, and that if they can decrease the amount of smoking, like even just go from a full pack to a half a pack a day, that will help them not only for their rotator cuff, but just their health in general.
We've got a comment that says 1 pack per week isn't that much.
Any smoking is too much, unfortunately, but no, it seriously does increase the risk of failure.
Yeah.
All right, so the end here. Yeah, we have 4 minutes, guys. So it's more complicated rotator cuff issues. I'm not going to rush through this because it's all there for you guys to review, and it's just a small handful of slides. Are there any other, or like the younger patient with an irreparable cuff tear who doesn't have glenohumeral joint arthritis? They're too young for a reverse total shoulder, so that's kind of the patient you're considering. But patients who are older, non-functioning cuffed, advanced glenohumeral joint arthritis, they are going to get a reverse.
They do great with the reverse. Reverse is
they do very well.
They really, in fact, they probably get better faster with the reverse than they do with the rotator cuff repair.
Right, exactly. So included in these last couple slides are some information about tendon transfers. This is not something that all shoulder and sports surgeons do. This is not something that we have to do all the time, but just to remember, these are things that can be done in more complex cases, right? There's cuff tear arthropathy. We touched a little bit on this. You can see the arthritis there, destruction of the glenohumeral joint arthritis, right? You most often with any of these things, we're starting with non-op management. And then we start getting into the discussion of arthroplasty. And the last couple slides, we touched a little bit on reverse total shoulder here. The deltoid has to be functioning for you to be able to do a reverse. And it changes, obviously it's where the ball becomes the socket becomes the ball, and it does work very well when appropriately indicated. But remember, there is not a great salvage for a failed reverse. So you have to think very carefully about who you're doing this type of procedure in. We wanted to go in detail through the rotator cuff repair and all the stuff that you're gonna see, how you're gonna evaluate the patients. So in summary, rotator cuff tears are very common and cause shoulder pain, nighttime pain especially. Many rotator cuff tears can be treated non-operatively. Remember that. A careful history, exam, and appropriate imaging are very important for effective treatment, and surgery can alleviate pain and restore function in patients. Most patients tend to do very well with this surgery. Here